The myotonometer was first developed to quantify impairments associated with spastic paresis. Most of the research that has been done with the myotonometer has been done in this area. Specifically, muscle tone, muscle weakness, and the level of severity of the spastic condition can be quantified. These data can be obtained in about the same amount of time as subjective and unreliable tests such as manual muscle testing and the Ashworth and Tardo scales. Also, unlike these subjective tests and computerized isokinetic testing, myotonometer measurements can quickly be obtained from postural as well as extremity musculature. Examples of the utility of quickly quantifying these impairments include quantifying treatment interventions, identification of treatment plateaus, documenting patient progress, and also increasing the ability to titrate drug administration much more effectively, because now the common side effect of muscle weakness can be quantified together with the effectiveness of tone-reducing medications and injections. What you will see next is a demonstration of one suggested protocol to quantify resting muscle tone, muscle weakness, and level of severity of the spastic condition.
The muscle being tested is the biceps femoris. The patient is positioned with the muscle in a lengthened position. The probe is pushed perpendicular to the muscle several times. The program will automatically average these measurements into a single force displacement curve. You have now obtained resting muscle tone. Next to be tested is strength. Note that the same position does not have to be used for resting tone. The patient is placed in the desired position and asked to give a maximal voluntary isometric contraction. A handheld dynamometer, holding a weight, or adopting a functional position that requires an isometric contraction, such as standing on toes, can be used if the therapist or physician suspects that a consistent maximal effort is not being performed. The screen you are now viewing shows the data just collected at rest and during contraction. This line shows the force displacement curve at rest, and the blue line shows the curve during contraction. Note that the resting tone is less stiff or more compliant than during contraction. Research has shown that the differences in the area under the curve of the two lines corresponds with the level of severity of the spastic condition and also to the modified Ashworth scale. To quantify this difference, select the percent difference tab. Thus, in one short testing session, the physician or therapist can quantify muscle tone, weakness, and spastic paresis. The next screen shows an example of hypertonia. In this case, the involved or contralesional muscle was compared to the uninvolved or ipsilesional muscle. Note that the more hypertonic muscle is stiffer or less compliant. Selecting the percent difference tab allows you to quantify the difference. The next screen shows an example of a paretic or weak muscle. The blue line represents the data taken of the muscle at rest, and the red line represents the data taken of that same muscle during maximum voluntary contraction. Note that there is very little difference between the muscle activation at rest and during contraction. Again, click the percent difference tab to calculate the percent difference between the two muscles. In the case being shown, this girl is asked to exercise her back muscles. With an increased effort, muscle stiffness increases. She's being shown how well she's doing. Data can be saved to show her progress over the course of time. Published studies have shown that the myotonometer is a valid and reliable instrument to assess the neurological patient. Please contact Neurogenic Technologies for publication references.